Great. Hello, thank you for joining us at Lunch Club. I'd like to introduce Austin Corpuz and Richard Davis present on their presentation. You guys can begin whenever you're ready.
All right, so we are presenting the first case. My name is Fentie. I'm a MS3. We are presenting a case, a mixed testicular germ cell tumor presenting as scrotal pain, it's a case report that we saw a patient at Piedmont while on urology rotation. All right, so I'll take the first part, and Austin will take from the second part from the case report. So we'll start from introduction. So testicular cancer accounts about 1 to 2% of cancer among men in the United States. The peak incidence of testicular cancer is age between 20 and 35. The risk factors are multifactorial, as like most of the cancers, family history is one of the risk factor, and environmental, crypto or credism, infertility, and Klinefelter syndrome and Down syndrome. Those are the risk factors that lead to testicular cancer. And unlike most cancers, testicular cancer is curable, about 95% cure rate even after metastasis to the organs. When we come to classification of testicular cancer, we classified based on pathology. We classified into two major categories, germ cell and non-germ cell tumors. And germ cell accounts about 95% of testicular cancer, and the germ cell further divided into seminoma, which responds to radiation therapy very well, and the other classification is non-seminoma. And the non-seminoma includes embryonal carcinoma, which is a very aggressive tumor among all other testicular cancer, and it can present as painful scrotal mass. The other non-seminoma is teratoma, which is common in children. It's composed of tissue from different germinal layers. It could on histology could show us like hair, skin, and just different germinal layers or different tissues. The other classification is testicular choriocarcinoma. It's known by its early hematogenous spread to the lung. Another one is yolk sac tumor. It's common in prepubertal age group. And the last one among the non-seminoma is a mixed of 1, 2, or some part of the non-seminomas. And the other classification, which accounts for 5%, is non-germinal cell tumors. Could be leading cell or Sertoli tumors. The leading cell tumors produce testosterone, and the Sertoli cell tumors produce estrogen, which could lead into gynecomastia due to excess estrogen. All right, when we come to the clinical presentation, most of patients with testicular cancer present as painless testicular mass. On examination, there's a negative transillumination test. They could present as dull lower abdominal or scrotal discomfort. It could present as gynecomastia too, especially in Sertoli cell syndrome because of Sertoli cell tumor because of excess estrogen. And the last one, it could present as cough, especially if it metastasized to the lung. Sometimes that could be the presenting symptom. And the next one is diagnosis. So ultrasound is the first step and the best step to diagnose cancer, testicular cancer. We can use tumor markers, including beta-HCG, AFP, and LDH. LDH is a prognostic. We use it for a prognostic purpose. The higher the LDH, the poor prognosis of the testicular cancer. After the diagnosis, the next step would be staging the cancer. And for staging, we use CT scan of the abdomen and pelvis, plus chest X-ray to see if there is dissemination to the lung. And we can do CT or MRI of the brain if there's a neurological symptom due to the fact that it can disseminate or metastasize to the brain. And we can do a CT of the chest and abdomen to see if there is metastasis to the retroperitoneal lymph nodes. One thing to note about testicular cancer is biopsy is contraindicated, unlike most other cancers where we use biopsy as a diagnostic purpose. Last one is management. So the mainstay of management for testicular cancer is radical inguinal orchiectomy, and that's the main management. But we can add sperm cryopreservation if the patient is planning to have children in the future. We can add chemotherapy. There's different regimens of chemotherapy. Could be carboplatin based for seminomas or cisplatin based for non-seminomas. And the last one is we can add radiation therapy, especially for seminomas, because seminomas are known to respond very well to radiation therapy. And I will pass it on to Austin for the rest of the case report. Thanks.
Perfect. Thank you, Ken. So regarding our case report, we have here a 32-year-old male who presented to the emergency department for an acute onset of a painful swelling localized on the posterior side of the right scrotum. The patient is sexually active, has a 5-year half-pack former smoker, and reports history of trauma onto the affected side. The patient describes an intermittent history of unilateral swelling and painful sensation emanating from the right posterior scrotum with accompanying dysuria. He admitted to recent changes in urinary frequency, has a normal urine flow upon voiding, but denied any history of hematuria. Furthermore, the patient denied recent onset of fever, weight loss, or general fatigue. An initial impression of acute epididymitis was made. Upon performing a physical examination, a unilateral erythematous firm hard testicular mass that is warm to touch was discovered in a normal orientation. An ultrasound was performed, which revealed a 3.1 by 3.4 by 2.6 centimeter heterogeneous right intratesticular mass with a small right hydrocele presented. The ultrasound showed a presence of arterial blood flow on the right testicle without evidence of anatomical testicular displacement. A diagnosis of testicular neoplasm was then highly suspected and surgery was performed. Prior to surgery, an initial blood work of AFP, HCG, lactate dehydrogenase revealed an elevation in AFP. A right oreectomy was performed and was sent to histology for review. Pathology revealed a 2.8 by 3.7 by 4.0 centimeter testicular mass composed of advanced mixed germ cell tumor with seminous component, embryonal carcinoma, yolk sac tumor, and malignant teratoma, limited to testes with good risk. The pathologic stage classification is PT1B, CN1, M1A, S1. So given the pathological report, post-orectomy staging metastatic workup with chest CT, abdomen, and pelvic scan with and without contrast was performed, which revealed lobar metastasis and abdominal wall metastasis. The patient had a PET scan, which reported an right upper lobe mass measuring 3.33 centimeters by 3.76 centimeters with a maximum SUV of 7.3 that is consistent with metastatic disease. Additionally, there was a metastatic lesion in the right hemipelvis measuring 1.6 by 1.26 with an SUV of 5.1. Blood workup was rechecked, which showed elevation of AFP and LDH, while beta HCG was still within normal limits. The patient was referred and seen by medical oncology team for further management. Patient was started on frontline chemotherapy with bleomycin, etoposide, cisplatin, and was scheduled for a PET scan upon completion of treatment. So pretty much in conclusion, the normal scenario is intermediate painful episodes of unilateral testicular swelling to the posterior scrotum with history of high-risk sexual activities prompt men to seek medical attention for suspicious of acute infection causing testicular pain. Well, as seen across the sparse literature regarding similar cases, the diagnosis of testicular cancer could be easily missed in this scenario. Despite an acute onset of posterior scrotal pain, dysuria, high-risk sexual activity, without constitutional system, a young male presenting with firm testicular mass should be worked up for testicular cancer. So pretty much to stress, proper physical examination and ultrasound aided in recognition of the underlying testicular neoplasm early within the course, which avoided delay in specific treatment. And that is our presentation.
Thank you so much for your presentation. Just making sure, did I get the second presenter's name correct?
No, it's actually Ken. He's in the screen
Okay,
right here.
that's what I thought for a second. I was like, oh, that's not Richard, that is Ken. I recognize the voice.
Yes, it's okay.
All right. Well, thank you so much, and I will share this to the drive and put a little announcement about it. Thanks for your presentation, and we will chat with you guys soon. Thank you so much. I'm going to end the recording now.
Perfect. All right.